Hello and welcome to today's Essential Together National Huddle. A warm welcome to the patients, families, and caregivers and essential care partners who are joining us today. We're pleased to offer this session with simultaneous interpretation. If you would like to hear the voice of our interpreter today, please select French from the interpretation menu at the bottom of your screen. Please note that this session is being recorded and the recording will be made available after the session. If you haven't had a chance to do so yet, please take a moment now to respond to the poll question on your screen. Please scroll down to see all the questions in both English and French, and be sure to click Submit to send your responses to us. As we begin, I'd like to thank our producers, Gina Peck, Kelly Ripley, and Brady Como, who are operating behind the scenes today and providing technical support for this huddle. At Healthcare Excellence Canada, we recognize that we are still learning how to respectfully support reconciliation efforts and develop meaningful relationships and partnerships with First Nations, Inuit, and Métis, governments, organizations, and communities. As part of this journey, we strive to support cultural safety and humility in the healthcare system and enhance the capacity of health systems to meet the needs of First Nations, Inuit, and Métis. I recognize that we are virtually gathering today from a variety of places across the country, and I acknowledge that my home office is located on unceded, unsurrendered Anishinaabe territory. The Anishinaabe have long been the keepers and defenders of the Ottawa watershed and its tributaries. I feel so fortunate to live, work, and play on this land, and deeply appreciate the opportunity to gather here today. I know that many of you are joining us from across Turtle Island, and I invite you to take a moment to reflect upon the territory and its original inhabitants where you reside. If you're unfamiliar with what territory you are on and the history that has built and preceded it, we have provided the link to a great resource, the Native Land Digital, in the chat. So please feel free to have a look at that and to share with us where you're coming from. As I introduce our guest speakers, I'd ask that you please take a moment to introduce yourselves in the chat box and where you are joining us from today. First, I'd like to welcome Jennifer Simon and Valerie Stewart from Alberta Health Services. Jennifer Simon is a registered nurse whose passion for family presence and patient family-centered care grew after caring for her husband while he battled a rare disease in hospital for a year. She now works for AHS, Engagement and Patient Experience Department, and lives and breathes her passion for this work in all that she does. Valerie Stewart is a registered nurse with many years of nursing leadership and a special interest in patient and family-centered care and family presence. She left a manager's role in 2013 to join the South Health Campus Patient and Family-Centered Care Department and subsequently the Calgary Zone Patient and Family-Centered Care team. Healthcare Excellence Canada is a newly amalgamated organization that brings together the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute with a relentless focus on shaping a future where everyone in Canada has safe and high quality healthcare. Essential Together is evidence-informed and responsive to the needs and priorities of patients, families, and caregivers, as well as organizations and those who deliver healthcare. Essential Together was developed to support the reintegration of essential care partners into health and care settings during and post-pandemic. It provides implementation support of co-developed policy guidance for those who make policy, those who implement policy, and those who experience and are impacted by policy. Supports organizations to safely resume welcoming back essential care partners, and has three main audiences: policymakers, those who implement policy, and those who are impacted by policy. And we do this through the evidence scans that we do routinely, our policy guidance, these national huddles that you're attending, our resources and tools, our pledge, and our change package. We're pleased and thankful for the 12 Essential Together supporting organizations from across Canada that have supported this work. Our foundational principles for Essential Together are the issue of family caregiver presence as an essential care partner, being multi-jurisdictional, and that there are similar concerns, challenges, and opportunities for policy conversations across the hospital sector, long-term care, and other congregate care settings. The foundational principles were co-developed as part of a 2020 collaborative policy lab process that included policy decision makers, health system leaders who implement policy, and the people who are impacted by policy decisions, providers, administrators, patients, families, and caregivers. This guidance was updated in 2021 based on evidence emerging throughout COVID. The Essential Together Pledge. The program fosters a community of organizations working together to strengthen patient and family-centered visitor policies within their own organizations, as well as throughout the sector. As a strategy to highlight organizations who have demonstrated the commitment to the foundational principles, the Essential Together Pledge was developed as a call to action and a way to recognize our partners as leaders in this area. In addition to access to the Essential Together resources and peer-to-peer learning opportunities, organizations take the Essential Together Pledge will be recognized as Essential Care Partner Champions, be publicly acknowledged on the HEC website and other materials as an Essential Care Partner Champion that supports person and family-centered care practices, act as a peer mentor to other organizations committed to person and family-centered care practices, and have access to coaching support as they take action on their commitment to essential care partners. I'm also pleased to recognize that many organizations have joined us in the pledge, including Hearthstone Manor in BC, Saskatchewan Health Quality Council, Forestdale Home in New Brunswick, Tideview Terrace also in New Brunswick, as well as MacEwan University School of Continuing Education and St. Joseph's Healthcare Guelph, as well as William Osler Health System in Ontario. And I keep getting Tideview Terrace, it's either in New Brunswick or Nova Scotia, and I believe it's New Brunswick, but I may have that wrong, and if so, I apologize. It's now my sincere pleasure to pass today's huddle over to Jennifer and Valerie. Please go ahead.
Thank you so much, Jessie, for that introduction. To start, Valerie and I would like to acknowledge that we are presenting our story of commitment to family presence from the territories of Treaty 6, 7, and 8, as well as the 8 Métis settlements and the Métis Nation of Alberta. We recognize that Indigenous people who dwell in our urban centers and across the lands, these territories are home for many Indigenous people, including the Anishinaabe, Blackfoot, Cree, Dene, Inuit, Métis, Stoney Nakoda, Sioux, and Tsuut'ina. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past. And we dedicate ourselves to moving forward in partnership with our Indigenous people in the spirit of reconciliation and collaboration. Go to the next slide. And Val is going to tell you a little bit about our organization.
Thanks, Jennifer. Good morning. Alberta Health Services is Canada's first and largest province-wide, fully integrated health system. It's responsible for delivering health services to the over 4 million people living in Alberta, as well as to some residents of Saskatchewan, British Columbia, and the Northwest Territories. We were the first province to embrace a province-wide approach to healthcare delivery. The formation of Alberta Health Services in 2008 was considered a bold experiment at that time. The transition to a single system hasn't always been easy, but today is proving to be an effective model to bring about transformational change to healthcare. By working together as one health system, we've been able to improve patient outcomes, enhance patients' experiences for our patients and families, as well as our over 130 plus hardworking staff, physicians, and volunteers. In other words, that bold experiment is working. Next slide, please. March 2020 hits, and we see the world's greatest disruption in a generation. When COVID first started, Alberta Health Services, like many others, were limiting family presence to end of life, critical care, labor delivery, and pediatrics. During this lockout, we had a really good look at what healthcare looks like when these essential partners are not included. There were many unintended consequences of locking out families. We experienced drastic increases in our patient concerns reporting specific to visitation in Alberta, as well as many negative impacts to patient experience. Anxiety, depression, responsive behaviors increased, and we saw the impacts on the use of restraints and antipsychotics. One study in Calgary noted a 9% increase in the use of mechanical restraints and a 21% increase in the use of pharmacological restraints. With that increased use of restraints and antipsychotics, patients were moving less, and that impacted the rate of deconditioning. We heard testaments of dehydration and malnutrition. The majority of our staff also reported that they felt moral distress at some time during the pandemic, and 53% reported experiencing moral distress at the time of the survey, which was in February 2021. Next slide, please. Virtual visitation was promoted throughout the pandemic, though many found this cumbersome to use, and some did not have the technology to benefit from us. Our health authority did its best to pivot and see how we could support more virtual options. Tablets were purchased or donated to support virtual connections. Volunteers provided virtual patient experience visits, especially with patients that did not have family to connect with. Virtual methods did and do provide some comfort and support, but they can also cause challenges, lead to confusion, and often escalate behaviors with patients with cognitive conditions. Next slide, please. Alberta Health Services sought to evaluate the impact of visiting restrictions on our patients and families. Several studies were done, and that data was used to inform our visitation guidelines. In one study, patients were asked if they were able to communicate with their family or friends, either in person or phone or by video calls as much as they wanted. 82% of our respondents did say yes. The 18% that indicated no listed such reasons as restrictions on the number of support persons, inconvenient visiting hours, technology issues such as poor quality internet and inability to manage the technology. They commented, don't have a cell phone, everyone is too busy. No one mentioned video calls, no help from staff. Next slide, please. And Jennifer, could you continue, please?
Yes, thanks, Val. So in May of 2020, AHS put together a task force after seeing the steep rise in patient concerns regarding access of family members. The goal was to reintegrate family presence while managing the risk of COVID-19. Members included operational team leads, patient family-centered care leads, infection prevention and control, workplace health and safety, protective services, clinical ethics, physicians, palliative care, continuing care, pediatric care, along with data analytics, patient relations, communications, and others. All coming together to help us understand how we could have both family presence and COVID risk mitigation. These various roles and champions have been key to the success in ensuring that we're seeing the whole scenario from all the different ways and all those affected by our decisions. This group has stayed together throughout the pandemic to manage the various waves and challenges of COVID in the last 2 years. We start our meetings by looking at patient concerns data and reminding of ourselves that there are real people being really impacted by the decisions we make. We look at both the data and the stories behind the data and connecting these trends to meaningful changes and improvement. We'll go to the next slide. Here's an example of a family concern brought forward and brought to life in this data. I wanted to see my wife, who's been in a facility all on and off for nearly 2 months. Her last stay has been nearly over 2 weeks. We have no idea when she'll be discharged. We are not allowed to see her because of COVID restrictions, but we are each other's only nearby immediate support system. Her mental health and mine are suffering greatly because we can't see each other. Mental health is a huge part of a patient's hospital stay, and my wife is declining rapidly, along with her physical issues. Because we can't see each other, video chats are one thing, but we are able to do that. But she is scared to death, as am I, about her physical health, and that has a great impact on her mental health. Holding her hand, giving her a hug, a kiss, her knowing I am beside her is something she seriously and desperately needs. She is 72. I will wear any PPE required, and I'm pleading with you to please make an exception for us. Let me see her even for an hour or two every day, or even every second day. I'm extremely desperate, and I believe her declining mental health will impact her physical health, and she will give up. We are each other's lifelines. So again, I'm pleading with you to let us see her. Next slide. We were so fortunate in Alberta Health Services to have a well-established patient advisory group that had already moved online and could meet with us several times as we looked to build our initial guidance and then throughout the pandemic to advise us. This group was key in direction setting, helping us define what is important and what values we need to uphold as we do this work. Next slide. In June of 2020, we launched our first guidance allowing family presence back into our site. Since that time, we have not locked out designated family supports en masse again. Definitions we stuck to was designated family support person was a person who the patient had chosen to be involved and was not bound by traditional definitions of family. We recognized that visitors were more transient and temporary in nature and more social in nature. We've allowed designated family supports at varying volumes during the peaks and valleys of COVID. We have, for the most part, limited visitors to end-of-life, extenuating circumstances, and outdoor visits when weather permitted. To manage this, we've added to our screening, our entry screening at the door, questions about if the person is a designated family support person, and the process for site screeners to verify that someone is actually the designated family support. Some units use a list brought down to the door that kind of has the patients for that day and who their designated family supports are. Some units are calling up to the unit and just validating with the chart that this person is indeed the designated family support. We amped up our public communication to help the public understand this role, getting really clear about who was a designated family support and who were visitors. We even asked our government to reflect this language in their press conferences. Next slide. So some have asked us why we did designated family support persons rather than essential caregivers. And early on, essential took on a look of being somebody who provided care and very task-based, with the staff deciding who was essential and who wasn't. If you were feeding or doing ADLs, you maybe were essential. If the staff couldn't provide a task that you could provide, then maybe you were essential. For this reason, we moved away from the word essential and actually chose the word designated to indicate that patient was in the driver's seat and that it was who they decide to have involved and how they wanted them to involve, and really reflected the need for their choice in that. Next slide. With the decision to move to a designated support, we also made this decision to commit to everyone having someone. Maya Angelou said, "Do the best you can until you know better. Then when you know better, do better." We recognized that harm was done when the initial lockdown happened. We knew better and needed to do better. And with that decision, we moved to designated support persons and committed to everyone having someone. Throughout the waves, this was tested many times and became a bit of a mantra for our task force group, that we were going to hold steady on everyone having someone. It wasn't a matter of yes or no, but how could we do this? How could we do this and keep it safe? We knew more about the virus by then and how to protect against it. We had good screening, PPE, public education. And so it became really about how we make this safe for our patients to have their families about. Next slide. We developed this resource known as the Know Your Risk, Role and Responsibility Guide for Designated Family Support Persons to help them partner as safely as possible with the healthcare system. We've done some measurement to see in one of our zones, they measured how well this education was getting out. And indeed, 90% of our designated support people were receiving education and information about hand hygiene, continuous masking, use of PPE. More than half of them were receiving education about limiting their movement around the site. And this helps us understand how our safety measures are being heard by our families. This graph also helps us show where we can do some improvement. And in the focus of COVID, we've lost a bit of our focus on comfort for our families. And so that'll be an area that we look to improve over the next few years. It is in hard days and times that challenge you that you find your very core, and it is how you determine who you are. This is from Sheryl Sandberg. In the Delta wave that hit us in the fall of 2021, Alberta became the center of national news, and not for the ways that we would like. Our hospitals were full, we were having to get creative and call in reinforcements. Our staff had experienced outbreaks and we're seeing how Delta was more aggressive. We were at our max and our staff were scared. Here's a quote from one staff member. Feeling that the staff safety is less valued than family visits, having family members visit who are confirmed COVID positive, or having family members lie about their isolation status. We've had several staff members exposed to COVID from visitors who were dishonest in symptoms. We were canceling surgeries, seeing outbreaks in most of our acute care sites. And it was hard for our staff to see how, when we're canceling surgeries, that we're still letting designated support people in. On top of this, we were also seeing the political divide come to our doorsteps, with protests happening on our hospital grounds. We experienced our most significant pushback to return to a lockdown of family presence during this time. It was a really big time for a gut check. We had to look at the data, look at the amount of DSPs and whether they were significantly or exponentially increasing the COVID risk in our hospitals. We needed to acknowledge that screening, continuously masking, hand hygiene had worked through the other waves. We need to acknowledge that we had higher levels of public and staff vaccination. We had to acknowledge that if we had the tools to keep our staff safe to come to work, then we had the tools to keep our designated support person safe. If you want to go to the next slide, sorry. I think 2 more slides. Sorry, I got behind. Thank you. And at this time, we had to really recognize that if we truly believe that family presence, no, one in the back. There, thank you. That if we truly believe that family presence was not a nice to have, but a need to have, that we needed to look at these guys as the same rules as our essential staff. Desperate times did call for desperate measures. And in this time, we settled on having 2 DSPs, but only 1 at a time. And we added the wording around that our DSPs could participate in care. Starting to recognize that if things got really bad, we actually might need them to kind of save the system from the point of breaking, and that they were happy to help and offer their patients a little bit extra and optimize the levels of care. Next slide. In the fall, we looked at the exposure rates of healthcare workers and recognized that less than 1% of healthcare worker occupational acquired COVID cases were attributed to visitors or designated family supports. These were in times where control measures had lapsed, such as a healthcare worker having physical contact with an asymptomatic visitor during the time the mask was dislodged, as the visitor was crying and droplets from the visitor's eye and face were in contact with the staff member. We needed to have clear communication that the protections that we had in place worked, and that the likelihood of virus coming from a designated supporter visitor was small. Next slide. There was a recognition that some circumstances needed further access limits, either due to infrastructure or an outbreak. And within our policy, we created what we hoped was enough wiggle room to meet these needs while having enough structure that we had a consistent approach. The policy defines that limits must be the least restrictive limit to manage the risk. They must uphold the current exemptions, keep sacred access for end of life, critical care, pediatrics, and maternity. That further limits needed to be evidence-based and facilitate alternatives to in-person access. We wanted them to be approved by a higher level so that the site could help find consistent approaches and problem solve issues to be able to return to in-person access as soon as possible. Any limit that was further needed to be reviewed every 14 days, 1 incubation cycle, to ensure that family presence in person was brought back as soon as we possibly could. We'd heard in a survey, and being such a large organization, it's challenging to get our 100,000 employees all on the same page, and inconsistency was a source of frustration to many. The provincial rules were not consistently followed, and in some facilities from unit to unit, some families were concerned and their efforts to advocate for their loved ones were rejected. Knowing that family presence was allowed elsewhere caused frustration and distress for families and patients and staff. These different ways that we interpreted the visiting policies is always a challenge, and it continues to be a challenge in an organization this big. What we wanted was that any further limits were for a purpose, and they followed a process and were limited, time limited. I'll hand it back over to Val now. Next slide.
Thanks, Jennifer. As Jennifer indicated, we wanted to ensure that everyone gets somebody and that designated support persons could be present safely. In addition to the Know Your Role, Know Your Risk guide, different strategies were employed to ensure that the designated support person could be safely present. The DSP Coach was one of those strategies utilized. We saw many others. It was modeled after the PPE Coach program. The designated support person coach is one of the current staff. It's not an additional staff member on the unit who's chosen by the manager and specifically trained to take on this role of providing support and coaching for the designated support persons to safely participate in care planning, decision making, in other words, safe access and visitation for those designated support persons. It was really important that the coaches maintained a current understanding of the current visitation guidelines because they changed often, and they acted as a resource for patients, families, and staff. They also coached the designated support person on donning, doffing, and hand hygiene. They made that connection with the designated support persons within 24 hours of admission and helped them to understand what to expect when they arrived at the campus. They also directed them to a DSP Coach video, a video that helped them to understand what to expect. It was created by the implementation team and on the AHS YouTube channel. Next slide, please. We did measurement, as Jen talked about, to evaluate if these strategies were working or not. Designated support persons were asked if they were able to communicate with the care team as much as they wanted. Again, 3/4 of our respondents said yes, but we also identified areas that we could continue to work on. Families didn't know that they could communicate with the care team, and staff was often not available when family called or visited. They commented, difficult to get a hold of, don't get back to you, don't see them, don't know their names, don't have any idea on how to connect. I didn't even know this was an option. Next slide, please. We also wanted to know if designated support persons were invited to participate as much as the patient wanted to. And you can see on this slide that the majority said yes. If you click again, you'll see that 31% indicated sometimes or never. Next slide, please. And we also asked if the hospital staff allowed their designated support person to be with them anytime they needed or wanted them to stay. Again, the majority said yes, but if you click again, you'll see that 15% said no, and again, 25% indicated I don't need or have someone. Next slide, please. We wanted to find out about the impact of the restrictions on our patients and families, and we identified several qualitative themes like loneliness. They talked about extreme loneliness, not being able to see their family. The number of visitors was a concern, not being able to change their DSP and time limits on visitors. And some of the respondents said, I find it harder to stay and heal like I should. I'd rather rush the process and get home to my loved ones. So having my family being able to come and support me here helps me relax and try not to rush the process as much. It comforts me. My designated support person is burnt out. I feel like family support is essential to patients' fast recovery and also to relieve some pressure on the staff. I can't see both my parents and my husband. I can't have my family with me together. It's just not the same over the phone. Next slide, please. Some of our participants actually described a positive impact of the restrictions. They said, like, I like not having to entertain when I'm sick. It's a much quieter place with no visitors, safer place for my family. Keeping them away is best. Weird, but having to talk sets me back a few steps every time. None, the restrictions are easily managed. Great being left alone to recover and not have to participate in answering questions. They described our staff as friendly, awesome, excellent, professional, and compassionate. Next slide, please, and I'll turn it back to Jennifer for our closing comments.
And I love how we recognize those positive comments of the limits. And I think it really reflects the continued need for patients to be in the driver's seat and have the choice about who and when people come in and how they interact. Recognizing that not everybody wants somebody, and some people are really happy to have a little less interaction. And I think that that's been a real lesson for us in Alberta, is that when we got clear on deciding and having the conversation about who should be in and who shouldn't be, it allowed us to really recognize the differences within our patients and how they want to be interacting with their patients and families. Our key messages really are to stand with your values. It's hard times, and I think this is when we're being tested the most. To think not in terms of yes or no, can they come in, but how can I make this safe? And then if you're going to have a limit, it should have a purpose and be with a process and have a time limit to it. I'll go to the next slide. Most of our family presence stuff can be found on this webpage here, the Alberta Health Services webpage. And if you have questions or concerns afterwards for Val or I, you can always contact through the patient.engagement@ahs.ca email address. I want to thank everybody for your time, and I'd like to thank Health Excellence Canada for inviting us to share our story of committing to family presence through the pandemic.
Thank you, Jennifer and Valerie. You know, you shared what's clearly been both challenging and rewarding work over the last 2 years plus. I know that this work didn't just start with the pandemic, that you've been proponents of family presence for many years prior to that as well in Alberta. So we now invite you to share any questions or comments with Jennifer and Valerie. And I see that we've got a couple in the chat box, so I'll work through those. And some of them are comments. So, you know, some very positive comments here from folks about keeping families in the driver's seat and making informed decisions and sessions together. The building of trust, taking negative experiences and making them work. That creativity and the bumpiness of the past sometimes, but really heartwarming to hear, and thank yous for sharing the work that you've been doing. There was one comment that I'm actually going to turn into a bit of a question, and it was around the sort of culturally exclusive and culturally exclusive approaches, and how this may lead to tensions and conflicts, and specifically about the language of essential and or designated care partners that may or may not be culturally appropriate for many East and Southern Asian families, where there's a relational nuance. I'm wondering if you have any memory of experiencing some of this, and then how did you address it, if you did? And if you don't, or you can't remember, that's okay. I know it's putting you on the spot a little bit, but I'd be curious to sort of explore that a bit.
I can't say that we really did, Val. I'd welcome any thoughts, or anybody else from Alberta who's on the team. If you have any thoughts, pop them into the chat box. I can't say that we really did have much concern about that. What we really recognized is that essential was being seen as something that we could like limit people coming in or out, almost like a checklist. Like if you check off one of these boxes, you could get in, but if you don't, you can't. And there was a big question about who was checking those boxes. You know, I think as a nurse, I want to say that I can provide everything for my patient, and I can help them with their ADLs, and I can help them feed. Am I the best person to do that? Maybe not, right? And so, you know, when we thought about a checklist that was really based on tasks, it really limited who could come in. And there was this feeling like, well, we're the staff, we can actually do this. They don't actually, it's not essential for a family member to come in. And so we really drove away from that and really wanted to put patients in the driver's seat for them to kind of identify who they wanted, how they wanted their people to be involved, and allow them to have the choice to recognize that people have different needs and different levels of involvement. You know, I think culturally, some of the big things that we heard was that we did keep our numbers pretty low. We did let people have somebody, everybody had somebody, but but our numbers were really low, and some families are much bigger than what our numbers allowed for. And I think you could see that in some of Val's comments that, having to choose between family members was really hard for our families. And so, these weren't easy decisions to come up, and, you're trying to manage the overall, social interactions for a site while still making sure that everybody has the support that they need, and at least some of the support that they need. And so, were we perfect every time? I don't know. It's hard to even know whether we did the right things or not. We're still kind of in the middle of it. I feel confident in what we've done, and I feel like it was a good balance. I hope that answers a little bit of the question.
It does.
And sorry, I was going to say we did have ethics on 24 hours a day, and they could help to sort out some of those questions if people did have any questions related to any cultural issues or any other issues that were either impacting our staff or our patients and families. They could have that direct contact to ethics 24 hours a day.
Thanks for that, Val. Sorry for interrupting. I didn't realize you were coming in there, but that's great to know as well. And I think it answers the question, but I think it's a continuing journey that that most organizations, and certainly people who are doing this work, are facing on a regular basis, as well as the people who are patients, families, caregivers that are coming in and out of different facilities and working with different organizations as designated or essential care partners, is sort of what is that lived experience that they bring, both from a health intervention perspective, but also from a diversity, equity, and inclusion perspective. And so appreciate the comments that you've made around that. Esha, I hope that addressed some of what you were getting at. Please let us know if there's more that you'd like to sort of have dialogue on, and we will welcome you to come on if you like to unmute today. And then there's quite a long comment from Dr. Andy Picard, so I'm going to read it and see where we get to and what your comments are on this. So, I strongly support differentiation of occasional social visitors from essential or designated support persons. While my wife's lovely facility readily acknowledged me as being essential, I gather that some facilities have used the BC rules to exclude essential people. As for safety, I and other essential caregivers I know are probably safer than most staff. We live very isolated lifestyles and observe hygiene rules scrupulously. Many staff go home to families who are active in the community, thus present a higher risk. Many of the BC rules relative to long-term care over the past 2 years have been detrimental to respect for provincial public health officials. Some rules are arbitrary with no obvious or stated scientific basis. I think that's something that we've heard from essential care partners, over this last 2 years, is sort of where are the infections, where is the spread coming from? And I think that absolutely there's some spread that's coming from the community, but even within times of isolation, I think that we knew that some of the spread was coming from those who are working within the different facilities. And any thoughts you have on that? I know that that as a health delivery organization, infection prevention and control is always top of mind when it comes to safety, along with the ensuring the care and the mental and physical well-being of your patients. So.
Yeah, definitely in the lockout, we saw some huge unintended consequences that definitely presented a patient safety risk. And so, I think when we're looking at restrictions, we have to recognize that those restrictions come with harm and risk of themselves. And so looking at a balanced approach, when Delta came, we really had to get in there and start looking at the data. And there's a bit of an absence of data around how much, institute healthcare acquired COVID cases were attributed to designated family supports or visitors. What we did have was some Alberta data around how much occupational cases, so staff cases, were attributed, and it was quite low. You know, I would love to see and hope that at some point we can gather some data around how much they contributed to patient infections. But globally, there's a bit of a gap in that data. So we did really have to kind of say, you know, our panic and as Delta's coming and it's looking really bad, our panic was to, okay, let's just close it down. And we really had to go back and say, do we have evidence to close it down? Do we have the right preventions? Do we have the right hows to make this safe? And really start asking those questions. And it was hard. Like instinctively, when things are scary, we want to kind of, you know, close the door and hold our people tight, or and it was hard to say, no, we don't have confounding proof that we need to just close them out again, and we need to kind of live our values and follow this science. But definitely, you know, these were a lot of the same conversations that we were having in our teams as well, to help us challenge these thoughts and these staff views. And I'm not saying that we did it perfectly. There's definitely staff where fear and what they had experienced with outbreaks and significant, losing a patient because of an infection that they got while they were in hospital, has a significant trauma to our staff. And so, there were definitely staff out there that weren't as ready and welcoming as there were other staff. And so in an organization this big, when you're not only living it in your job, but you're living it and taking it all home too, there's no way to get away from COVID for our staff and no break from it. There was definitely a big stress. And so I think we set the principles and policies in place to lead our organization in a positive way and to be able to coach towards those things and have the right conversations. Did it always work? Probably not. I think that's the truth of a big organization that covers a large geographical area.
Thank you. And certainly we have to recognize that lived experience comes both from patients, families, and caregivers, but also the staff that have worked so hard over this time period. And, we're seeing the results of what they've done now in terms of the HR crisis that we're seeing and the need for those additional mental health and recovery and resilience strategies to support staff who have been through COVID as well. So a couple of comments. You're really trying as a patient in the health system. That warms my heart. It's truly reflective of what people-centered care is. We have to partner together and hear all voices. Deeply grateful for your authentic work, the authentic work that you've done. And another comment about the wonderful presentation. Valerie and Jen, thank you for continually advocating for family presence across Alberta. And then there was a question, I'm just looking at our time, were there exceptions made to a single designated support person for specific situations, example, palliative care or other?
Yeah, so we had exceptions pretty much right from the beginning. So end of life was something that we kind of held sacred to, allowing up to 3 designated support people and visitors by appointment. And that allowed us to kind of manage the social distancing that we still needed to do between visitors or designated supports that were in different households, managing that we didn't have a bunch of people standing in a hallway and things like that. So we did keep definitely really protected against for those areas. Pediatrics, really recognizing that there were 2 parents and they really both needed to be in kind of together and all the time. We tried really hard to make sure that that was protected. Maternity, looking at that, and throughout the phases we've had some times where we felt a little bit more comfortable with opening the doors of maternity, such as opening it to surrogates or doulas. At other times, it didn't feel as safe, in the middle of Delta wave. And so we really held close to, you can designate. If you designate a surrogate or a doula, that's your designated person. You have the choice to designate them, but we're going to kind of not have as many exceptions to that. We recognize that there were exceptions by the government, exceptions around who could come in if they had symptoms of COVID or had tested positive. So pediatrics, we recognize that parents still kind of needed to take care of their kids and speak for them and make decisions for them. And so provincially, there was a government or a exception for parents of pediatrics to come in. Same with caregivers of adult dependents were allowed to come in even if they had symptoms, or actually maybe it was just they had close contact but not symptoms. I'd have to look at it again. But there were some exceptions around that, around the isolation orders to even allow people to come in at those key times.
Thank you. So I'm going to move us into a wrap up. There are a couple of additional comments in the chat box. So if you have a minute to have a look and want to answer those, that would be great. Just going to adjust one thing on my screen. There we go. So again, thank you, Jennifer and Valerie. This has been a really interesting conversation and learning about what's been happening in Alberta, because again, as people who are outside of Alberta, we heard the news, maybe not in the way that you wanted. And so it's really been fantastic to hear about what you've been doing in the background and in the foreground of ensuring that, designated support persons are available and have access to be with their loved ones, and their loved ones have that support when they need it. So pleased to announce that Tideview Terrace Nursing Home, an Eden Alternative Registered Facility located in Digby, Nova Scotia, got it right this time, will join us on April 20th for our next conversation, our next Essential Together Huddle. And they're going to chat a bit about how they've welcomed essential care partners during COVID, any barriers and facilitators, and why they have taken the Essential Together pledge. Our next huddles following will be May 18th, June 15th, and July 20th, and we'll share more about the huddle themes and speakers as they're confirmed, but please check back to our website to get more of that information as it becomes available. If you're interested in presenting as a member of our Essential Together group, please do let us know, because we would love to hear from you and what you're working on in your region or area of the country or care setting. There's always lots to learn from these conversations, and we really appreciate those who are able to share. I'd like to wrap up by thanking our speakers, our HEC staff and team of interpreters who make this happen behind the scenes. And of course, thank you to our audience for joining us today. We'll be emailing a list of additional resources as well as a link to the recording of today's session, which will be available on the ET Huddles page on our website. And you're also welcome to reach out to the Healthcare Excellence team to connect at any time. Thank you so much. And we ask you to take a minute to tell us about your Huddle experience by responding to our poll. And while you do that, I'll say a final thank you and let folks know that after a few minutes, we'll close out today's session. Look forward to seeing you in April.